our attention now to discussing stress deprivation and how that creates a response in tissue. Peacock told us in 1966 that joint stiffness results from a combination of trauma and immobilization. In other words, trauma and stress deprivation. Ehrman Madden in 76 showed that new tissue subjected to stress will elongate. In other words, we can determine the response of tissue by the stress we apply. Axon and colleagues in 1980 confirmed that soft tissue is primarily responsible for the joint stiffness. It's not the joint itself, but it's the surrounding soft tissue. Light and colleagues in 1984 suggested that a low load and prolonged stretch is more effective than a high load. They were looking at the treatment of knee contractures. We all know that prolonged joint immobility is non-physiological. This immobility creates excessive collagen cross-linking and stiffness. In focusing on stress deprivation, the stress deprivation can come from two sources, either applied immobilization or maladaptive movement that is limited motion. In either case, the joint is deprived of its normal stress that maintains its physiological balance. We know that even uninjured immobilized joints will have profound interarticular and periarticular changes as a result of the lack of stress. These changes are histological, chemical, and mechanical. All the characteristics about human tissue change when you remove the stress of movement. We know that these basic changes are important because we need to maintain the elastic factors of collagen, and we need to maintain the health of the ground substance. Joint stiffness results from increased cross-linking, decreased water and glycosamine glycan, which is the lubricant within the cell matrix, and it results from increased collagen turnover. Basic histological, chemical, and mechanical changes. Ligaments lose their fiber orientation when movement is reduced or eliminated. Their mechanical properties of strength are greatly reduced. And even though they don't shorten in terms of actual length, the fibers are not properly aligned, and that results in what we identify as shortening because movement is limited by the inability of the ligaments to move in relationship to the other tissue. Here in a drawing from Emil and colleagues, we look at the pink line, which is the control subject, which has not been immobilized, in comparison to the immobilized subject. And we can see at a much lower load, the immobilized lateral collateral ligament fails, whereas the unimmobilized limb can tolerate more than twice as much stress of load before it fails, clearly showing the increased strength of tissue that undergoes movement. Let's take the example of the dorsal apparatus. Here, the red lines represent the longitudinal fibers, the blue, the transverse fibers, and the purple, the oblique fibers. These fibers must move differentially. During extension, they are relatively more parallel, and during flexion, they change in their angular relationship to one another. If this movement of tissue layers is not possible, flexion cannot occur. The injury occurs, there is tissue adherence, which creates a maladapted pattern of movement, and the cortical remapping that results from that change of movement, and no change occurs. In other words, stress deprivation created by an injury creates this cascade of events that contributes to prolonged stiffness. Cortical remapping is perhaps the area that is most important in regaining motion, and yet for us as therapists who tend to focus on mechanical problems, I think it is perhaps one of the last areas where we allow our focus to turn. So let's look at the cortical response to stress deprivation, in other words, reduced movement. We know that we have a motor cortex and a sensory cortex, and that the motor cortex controls our active movement. The amount of stimuli we provide through movement is what determines the representational area within the motor cortex of the brain. Recent study has proven that changes in the motor cortex representation can occur very quickly in direct response to muscles used. This drawing from Silva and colleagues from '96 shows us a representation of the response to nerve injury and repair. Here are the normal representation of the fingers within the brain, with these bars representing the colors that are on each finger. Early after the injury of a nerve, there's no information. Everything's silent. There's no sensory input. As the nerve begins to regenerate and there's functional reorganization, things are disorganized because there's axonal misdirection as the nerve regenerates. So we see that the response to nerve regeneration is highly disorganized. But over time, those responses can change and be altered by virtue of the input of sensory retraining. Changes in input creates what is called cortical competition. In other words, the normal uninjured hand would have a specific representation based on use by the individual. And after injury, when part of that is removed, there's competition for the remaining space. We as humans develop what is called a learned non-use. We learn when one limb will not function normally for us to switch over and use the other limb, and we allow our brain to shift about the cortical representation of our motor pattern. Monkeys that had one forelimb denervated got along very well on 3 limbs and continued to reinforce this behavior. Let's look at this lesion in the brain created by a stroke. Here is a representation of the areas before any lesion. And you can see that the green and blue represent the elbow, the digits, and the wrist and forearm. Then there is a bleed within the brain or a lesion, and that obliterates a part, particularly of the blue, which is the digit, and the green, which is the wrist and forearm. Without therapy, the spontaneous representation changes. And interestingly, the digits now, even those areas here that were not affected by the bleed, greatly diminished because they're not being used. The wrist and forearm, if you look at the green in comparison here, is also greatly diminished in its total area. And now the face is being represented in this area, which before had no representation. And looking at the blue, the darker blue, if we look at the total area of the darker blue, we see that it's greater than in these areas, suggesting that the elbow and shoulder, which are unimpeded perhaps, have taken over. But what is so encouraging and so fascinating is if we take this same individual and they undergo therapy, we can actually change the representation and recreate a closer to normal representation. One can see that it is not identical to the pre-lesion, but that the proportional representations are significantly more similar to the pre-lesion than the spontaneous response without therapy. If indeed we are able to influence this following a direct lesion to the brain, why do we not harness this ability in our therapy process with the chronically stiff hand? We know that it only takes 9 days for the motor cortex representation to diminish significantly when the hand is immobilized. A study in 2009 took normal individuals and immobilized one hand and wrist. And testing following this immobilization showed that there was impaired tactile acuity, there was reduced activation of the finger representations within the motor cortex, and there was an observation of compensatory effects on the contralateral side from a brief period of immobilization. Significant somatosensory changes occur in response to immobilization of any type. In a study in 95, human ankles were immobilized, and there was a direct correlation between the length of immobilization and the decrease in the cortical area representation of the muscles that move the ankle. Here we see that graphically illustrated. The unaffected muscle was much larger than the immobilized muscle of the tibialis anterior muscle used in this study. How does stress deprivation relate to edema? Edema is always present in response to injury because it is the normal response to injury. I used to think that you could take the analogy of unzipping the hand and pouring in glue, because edema was the glue, and it was this glue that would set up and begin to harden. That is not an accurate representation. Edema does not cause stiffness. It does not cause stiffness directly. It does, however, fill up the interstitial spaces, providing pressure and thus resistance to movement and preventing movement. It's the lack of movement which creates the stress deprivation, and that's what creates stiffness. So it's a domino effect with edema. Edema is present, that reduces the ability to move. The lack of movement reduces the stress, and that is what increases the cross-linking and creates stiffness. So it's not the edema alone. Yes, the initial effect of edema is stiffness as we perceive it, because motion is limited because there's not room to move. But if the motion does not improve, prolonged edema continues and becomes a chronic inflammatory response. Because of the inability for the lymphatic flow to occur at its normal rate, there is an accumulation of the plasma proteins. So we need to reduce the initial effect of edema to create motion to prevent this chronic inflammation, which results in fibrosis. Injury does create edema. Edema limits motion and creates what we call stiffness. Stiffness then, because of the limited motion, reduces our ability to pump, and that increases the edema. Inflammation increases because of the increased edema and the inability to recreate normal homeostasis of the tissues, and that leads to more edema. And the vicious cycle is created and is very difficult to break. Now I'd like to shift gears to discuss very briefly the presence of interosseous muscle tightness. In my opinion, this is often the single greatest contributor to prolonged joint stiffness of the interphalangeal joints. It is underappreciated and undertreated. In our online courses, there are other courses that look at interosseous muscle tightness very specifically and explain how to test and how to treat it. Therefore, we will only provide overview comments in this presentation. There was an avulsion fracture of the base of the proximal phalanx on the right middle finger, resulting in limited extension and very limited flexion. This patient, when the metacarpal phalangeal joint was brought into hyperextension versus flexion, showed that the hyperextension of the MP joint was limited to +8 degrees with 68 degrees of passive PIP joint flexion. With the MP joint flexed, it had been 74 degrees. Reduced passive PIP joint flexion when the metacarpal phalangeal joint is extended versus flexed is a positive finding for interosseous muscle tightness. Interosseous muscle tightness is often called intrinsic tightness, which actually is an inaccurate term because both intrinsic muscle groups in the hand are not involved, and therefore interosseous muscle tightness is a much more specific term. To elongate the interosseous muscles, the metacarpal phalangeal joint must move toward hyperextension concurrent to PIP joint flexion. This can be done passively because the interosseous muscles have a secure bony origin, but it also can be done actively with the power of the extrinsic flexors. As long as there is an external device to support the MP joint in hyperextension, the extensor digitorum communis cannot hold against tightness of interosseous muscle. The extensor digitorum communis does not have the power to hold the MP joint in hyperextension during active IP joint flexion. It is interesting to note that the active motion is the only way to elongate the lumbrical muscle. And therefore, if the lumbrical muscle also demonstrates tightness, the active hook with the MP joint supported in hyperextension is the only way to elongate both the interosseous and the lumbrical muscles. I encourage you to review the other material on this subject so that this becomes increasingly clear. Blocking with an external orthosis allows both interosseous and lumbrical muscle elongation, which is necessary for full finger flexion. The FDP becomes active to elongate these muscles in preparation for regaining full finger flexion. It increases the joint range of motion of the interphalangeal joints and decreases the edema within the fingers because of the active pumping and the contoured pressure in the palmar area. Interosseous muscle tightness was a significantly limiting factor for this patient, in addition, of course, to edema and joint stiffness. But with focus on reducing interosseous muscle tightness, you can transform a hand from this to this.